Thanks, Rob. And thanks for the, actually I'll hold my reservations on my thanks to the coordinators, because the last time I gave a talk on this topic, I felt like I was rethinking my decision to go into endoscopy and maybe should have become a rheumatologist, because this, as you'll see, is a very controversial area in endoscopy. So I took the liberty of expanding the definition of iRAP to a few entities, as you'll see. Initially, I'd like to talk about just the potential causes of what RAP is, to try to move that I, take that away from the acronym. What is the natural history, so that if we're going to imply that endoscopy impacts the natural history, we really need to understand what its true natural history is without intervention. And then where does ERCP fit in 2014 as a diagnostic tool and as a therapeutic tool? And I'll touch on minor papillotomy, biliary sphincterotomy, and then pancreatic sphincter therapy as well. So how can endoscopic therapy change the natural history? Well, clearly if you're implying that the cause is at the level of the sphincter, then by treating the sphincter, you should eliminate future episodes. And of course, that would be the best case scenario and the most definitive. However, one could argue that by reducing the number or frequency of future episodes, or the severity of those episodes, potentially preventing the need for hospitalization, that also may be an important endpoint. As we've heard in earlier talks yesterday, that many patients with recurrent pancreatitis will go on to develop overt changes of chronic pancreatitis, and if we can lower that risk, that may also be a meaningful endpoint. And then more subjective and difficult endpoints to measure, such as quality of life and pain assessments. These are very important, but very challenging to measure in the clinical setting. What are the negatives of endoscopic therapy? Well, it's still a high-risk procedure despite technical and pharmacologic modalities that have been shown to reduce its risk. Post-ERCP pancreatitis is critically important, particularly in this disease entity. If we're embarking on an intervention to eliminate episodes or reduce their frequency, if we cause pancreatitis from our efforts, that must be considered in the measure, and the implications of inducing pancreatitis may be substantial. That may initiate downstream fibrosis that we currently do not fully understand. And then, of course, the therapies themselves are potentially hazardous. We've learned that stents may induce injuries to the pancreatic duct, so stent-based therapy in the pancreas has become much more cautious for non-obstructive disease. And then in pancreatic sphincterotomy, the risk of sphincter restenosis may actually become an aggravating factor in the patient's course and can cause substantial downstream sequelae, and so that also must be considered. So is it a problem? We saw this slide yesterday, but I do just want to touch on it again. The risk of recurrence after a patient has one episode of acute pancreatitis is not to be ignored. Of course, the red curve for alcoholics who do not quit, they will come back with more episodes. But focus on the light blue line here, the idiopathic entity. These patients will have a 20 to 40% risk of having 2 or more episodes. And so one could argue that for a patient who has their first episode without a clear definition, that perhaps we should be reconsidering our current management of saying, well, let's hope it doesn't happen again, and we'll see what happens. The other element from this study from Dheeraj Yadav and the Pittsburgh group is that the idiopathic subgroup is an increasing problem with age. So in the older population, this is a substantial subgroup of those who present with pancreatitis. And so again, it may impact the age of the patient may impact your thresholds to pursue second-tier testing. And then the other point to highlight here is that this is a very challenging, very enigmatic disease to study. And why is that? Is because if you offer an intervention for a patient and then you reassess their outcomes at 1 year, you may presume benefit when benefit has not been achieved. And so you can see that the curve continues to rise for that second episode up to 3 to 5 years later. And so I would say that any sort of prospective study of intervention, really you have to follow these patients for a minimum of 3 years and perhaps even longer. So be careful who you're calling idiopathic in this day and age. We now have MRCP, we have endoscopic ultrasound, which we've heard a lot about. secretin enhancement of both MR as well as EUS probably helps, particularly in the identification of early structural changes of chronic pancreatitis and pancreas divisum, and then a greater understanding of genetic testing, where we are now applying that to our patient population, particularly those who are at a younger age, for lack of a more precise estimates, probably folks that are less than 40, obviously a family history, and as we've learned with pancreas divisum, that is a marker of higher probability of having a genetic abnormality. So where does ERCP fit in 2014? We heard from Peter Cotton yesterday that it was a transformative diagnostic intervention in the late 60s and 1970s when there were no good, less invasive modalities to image the pancreas. That's clearly not the case now. So for patients with unexplained pancreatitis, I'm highlighting three entities here to discuss, and this is what I'll touch on in the rest of this talk. One is pancreas divisum, one is microlithiasis, and the other is sphincter stenosis or sphincter of Oddi dysfunction. Each of these is highly controversial as being a cause for unexplained pancreatitis, and so really merits discussion in each and of themselves. So is ERCP a helpful imaging test in this era of MRI and EUS? This is a study from Mariani and colleagues of 44 patients who had both secretin ultrasound, endoscopic ultrasound, and secretin MRCP. These were patients with recurrent pancreatitis, and a suggested etiology from either of those modalities was identified in 64%. This includes some parenchymal changes, and we've heard from Tyler and Brenda that this is somewhat controversial. But importantly from this study, no cases had an etiology that was identified by ERCP which followed those less invasive options. A study from Indiana, which I think is thought-provoking. These are individuals with both recurrent pancreatitis as well as chronic pancreatitis that is unexplained. And if you look in the top set of columns here, folks with both idiopathic acute pancreatitis as well as chronic pancreatitis, if you have an MRI that demonstrates divisum, in fact, when you follow that with the ERCP, you will have cases where the divisum is falsely identified by MRI. And then furthermore, divisum may be missed by MRCP in some cases. The accuracy of MRI is much better when you don't have chronic pancreatitis changes, but it's still, according to these data, is not in the north of 90 to 95%. And so there is a potential that ERCP will rule in or out divisum that has been missed or falsely identified by MRCP, and I think that's a point of debate. But then the question is, who cares? So what does divisum really mean? And I think that this has been now raised back up to the front of the table again in terms of what are the implications of even identifying divisum. So for divisum to matter for an endoscopist, then a minor papillotomy must induce some benefit. The reason that divisum has now been drawn into question is that its prevalence is not thought to be much higher than the normal population. When you compare folks with idiopathic acute pancreatitis or chronic pancreatitis and you compare them to healthy controls, the prevalence is still in that area of 5 to 10%. And that's furthermore is true for patients with what's felt to be alcohol-induced pancreatitis. And so it's not even a modifying risk for those individuals with a known environmental trigger of alcohol. The other compelling observation that's now been shown in several studies is that it clearly is a phenotypic marker of having a higher probability for a genetic abnormality, particularly CFTR, and some have argued that it may in fact be a protective embryologic phenomenon to protect against the viscous juice that CFTR mutations will lead to. And so this is very difficult to argue against. On the other hand, we have one small and unblinded randomized trial of patients with recurrent pancreatitis and pancreas divisum. This is from 1992, so in response to Peter Banks' comments at the end of yesterday, which I thought was a great way to end the first day, sort of motivating us. It's somewhat embarrassing that we have now gone 22 years, and this is the only randomized trial to date looking at the efficacy of minor papillotomy. But nonetheless, 19 patients who were randomized to passage dilation and stent therapy, so not papillotomy per se, were in the treatment group versus no stenting in the control group. Again, the intervention was not blinded. Patients were followed for an average of 29 months, but a range is not provided, so some of these patients are probably closer to that 1 year mark, which I think is problematic. So an outcome such as this, it'd be better to follow them for a minimum of 3 years or 36 months. But nonetheless, again, a good effort, as Peter Banks had mentioned in some of the other clinical trials that have been done in these difficult areas. The results are very compelling that by improving drainage of the dorsal pancreatic duct, you can improve abdominal pain, you can eliminate acute pancreatitis in many, and you can improve an overall assessment of improvement by more than 50%, which is a subjective measure in the majority. And so this is really, again, the only randomized trial. There are many cohort studies, and I'll highlight one of the more recent, that also suggest a potential benefit for minor papillotomy. And this is a cohort of individuals with divisum. And when you look at divisum, there's typically 3 subgroups. There are patients, the cleanest group are the patients that have recurring bouts of acute pancreatitis, but no phenotypic morphologic changes of chronic pancreatitis. Then you have folks that have chronic abdominal pain and chronic pancreatitis, and then you have folks who simply just have abdominal pain. And the most encouraging results for minor papillotomy are seen in those with tried and true recurrent pancreatitis based on standard definitions. However, again, the definitions are a moving target, much like Tyler mentioned in his talk in assessments of chronic pancreatitis. Here, the definition is a 50% reduction in the annual episodes of acute pancreatitis, ER visits, or hospitalizations. So we're not talking about elimination of pancreatitis episodes. And again, the follow-up is probably not as long as it needs to be for a disease that can be somewhat unpredictable. So, can pancreatic duct obstruction cause acute pancreatitis? And if so, how could sphincterotomy attenuate recurrent acute pancreatitis? There's a very compelling physiologic background to this, and that is that intermittent or sustained elevation in the pressures within the pancreatic duct will cause acute pancreatitis. Duct obstruction or spasm will cause acute pancreatitis in animals, and in fact, many animal models of pancreatitis include basically causing this to trigger an episode of acute pancreatitis. Gallstone pancreatitis, I think we can all agree on that, exists, and that exists primarily through transient obstruction of the pancreatic duct. Furthermore, what we've learned from ERCP provides further data. First of all, just by causing trauma at the level of the sphincter in our efforts to cannulate will cause pancreatitis. There's convincing data that pancreatic duct stenting will reduce the risk of post-ERCP pancreatitis, and by over-injecting the pancreatic duct, thereby causing a transient elevation in pressure, that will also increase your risk for inducing pancreatitis. So there's a lot of physiologic background to suggest that by reducing that pressure gradient, you can impact the course of, you can potentially eliminate pancreatitis in some of these unexplained cases, or at least mitigate or reduce the severity or frequency of episodes. In terms of microlithiasis, and so this goes along the lines of where biliary sphincterotomy might fit in, clearly for patients that have a high risk of having biliary pancreatitis or stone-induced pancreatitis, by doing an empiric cholecystectomy in those, or not empiric, but a cholecystectomy in those patients, you can essentially eliminate future episodes. But as you move down the spectrum to individuals that do not have the laboratory elevation, so a threefold elevation in their liver chemistries, nor the evidence of stones on cross-sectional imaging, then the benefits are reduced dramatically, and really no benefit. And so this is an argument against biliary drainage as being a modality to prevent pancreatitis. On the other hand, for patients that have probable biliary pancreatitis where they're not a good candidate for cholecystectomy, biliary sphincterotomy and or stent placement is very helpful, and by doing an ERCP in these individuals, you'll reduce their likelihood of having a recurrent episode by 50%. And this is a large epidemiologic study that was published in 2013 that's very convincing. And so I think most of us will practice this, that for patients who have a high probability of biliary pancreatitis, if they're not a good candidate for a cholecystectomy, then an ERCP with a biliary sphincterotomy is appropriate. It's much more muddied when you leave that population and you go to a population where the probability of stones drops dramatically. And so this is a cohort study of individuals who underwent an empiric biliary sphincterotomy for what was classified as idiopathic recurrent pancreatitis. And you can see the recurrence rates are in the range of 15 to 30% in all categories, irrespective of how they were subclassified. If they identified microcrystals in the bile, if there was fluoroscopic evidence for papillary stenosis, if the patient had manometry and was found to have an elevation in their basal sphincter pressure, or any combinations of these things. And again, the follow-up was limited, and there's no comparison sham group. And so while the recurrence rates are low-ish, we don't really know if it was the sphincterotomy or if it's the natural history in these populations that's driving these outcomes. So what about pancreatic sphincter therapy for iRAP? There's 2 randomized trials. This was the first. These are patients with actually normal sphincter manometry after having unexplained pancreatitis, who were randomized to serial pancreatic duct stenting every 3 months for 9 months, and a sham group. The PD stenting was 5 or 7 French barbed stents. Again, they underwent this basically quarterly for a total of 9 months. And the follow-up was, again, short in many patients. So if you look at the average follow-up, it looks good, but if you consider that half of the patients were followed for less than 3 years, that's a limitation. Because this is really a time-to-event phenomenon. It's not a dichotomous outcome of yes-no when the follow-up is variable. That being said, it was the first randomized trial of this nature, and again shows encouraging results that perhaps stent therapy will eliminate future episodes. So only 2 of 19 patients who were randomized to stent had a recurrent episode versus 53% in those who were treated with sham. The comparator outcomes for pancreatic type abdominal pain and being able to reduce or eliminate that, as well as for the interval development of chronic pancreatitis, was not different with endoscopic therapy. So this and other smaller non-randomized studies prompted Dr. Sherman, my mentor, to initiate a trial, which we then finished and published in 2012, which was a randomized trial of patients with unexplained recurrent pancreatitis, where the randomization was predicated on the results of pancreatic manometry. So patients with normal manometry were randomized to sham therapy versus biliary sphincterotomy, whereas those who had an elevation in their pancreatic sphincter pressure were randomized to biliary sphincterotomy, which at the time of study inception was considered standard of care, versus a dual sphincterotomy where both sphincters were cut. And this trial took many years to recruit at a single center, because this is, again, a relatively rare disease for an individual center to try to enroll, and patients' appetite to participate in such trials is often challenging, particularly in the United States. But despite that, very compelling results here, which is that, first of all, if you look at those with an elevation in pancreatic sphincter pressure, so we randomized 69 patients, 33 to biliary sphincterotomy and 36 to dual sphincterotomy, there was absolutely no benefit of ablating the pancreatic sphincter. And in fact, if you look in the first 1 to 2 years, the recurrence rates were higher in this group, and that may have been an issue of inducing more injury at the level of the sphincter in an effort to treat it. The randomization of patients with normal sphincter pressures was less than target, so this is only 20 patients. No benefit was suggested, again, by an empiric biliary sphincterotomy. The sample size is really too small to make any vast conclusions from that, but it's discouraging. However, the first thing that struck me when we created this curve and looked at it, is notice how the curve for the patients who had an elevation in pressure at the beginning, notice how much worse those patients did compared to those that had normal pressures. And I think that that's very thought-provoking. We were not powered to do proper post hoc analysis, but despite that, you see a hazard ratio of 4-fold higher elevation for patients who had an elevation in pressure. Their likelihood of having another episode in follow-up was 4 times greater than those who had a normal pressure at presentation. And so I think it's a harbinger, the test is clearly a harbinger of a more severe phenotype. I'm not sure that it necessarily means that we're identifying a group that will benefit more likely from sphincter therapy, because we saw absolutely no benefit in this study. Again, to highlight that this is a disease that requires prolonged follow-up, and so the majority of patients, all patients were followed for a minimum of 1 year, but the majority were followed for 3 years, and you can see that you need to follow these folks out at least that far in order to be able to quantify their likelihood of recurrence more accurately. And the last is that, consistent with other longitudinal studies, the patients who with RAP are at very high risk of developing overt changes of chronic pancreatitis in follow-up. So this is obviously very discouraging and a negative study for endoscopic therapy, and so at this point one cannot recommend pancreatic sphincterotomy for unexplained recurrent pancreatitis without more compelling evidence. The study was limited. Again, the sample size is still small, despite the fact that it's the largest, 69 patients with elevation in pressure and only 20 with normal pressure. A large benefit was anticipated and probably should be observed given the risks of pancreatic sphincterotomy. The homogeneity of the iRAP patient population should be drawn into question. Not all patients had an MRCP, not all patients underwent genetic testing, and I think we still don't really, we could probably disagree on what it takes to really classify someone as idiopathic. Without having a sham group, we really can't comment on the benefit of empiric biliary sphincterotomy, although again the data are not very encouraging in that regard. We still need to look at other important outcome measures that I started this talk with, which is what is the impact on the frequency of episodes, quality of life and pain outside of acute pancreatitis episodes. These things really require a blinded allocation to different treatment groups because many of them are highly subjective, and so this needs to be done in a new study going forward. So what are our next steps? Well, I think the diagnostic yield of ERCP after second-tier imaging appears to be very low, but I think it is reasonable to consider this for further study, considering that at this point there are no other alternatives for patients. So to dismiss them completely, and I did not mention other less common things such as anatomic congenital abnormalities such as common channels and so on. The diagnostic yield should be explored further, but it is probably very, very low, and so ERCP as a diagnostic test has fallen by the wayside to a great degree. We need better comparative effectiveness studies with long-term follow-up. And really one can argue that while acute pancreatitis is fairly objective, it's hard to fake it, still there is a lot of subjectivity in defining it as an entity and defining its severity, and so any sort of future trials should be in a blinded fashion to those who are adjudicating the outcome and obviously to the patients themselves. I think this is needed clearly for minor sphincterotomy or papillotomy for complete divisum in the setting of recurrent pancreatitis, empiric biliary sphincterotomy, and pancreatic sphincterotomy or a surgical sphincteroplasty intervention for patients with unexplained pancreatitis, probably one that also confirms a normalization of that gradient pressure following the actual intervention to make sure that you're treating it adequately. And then none of this can be done without appropriate collaboration with non-endoscopists, experts in the pathobiology of acute pancreatitis, pharmacogenetics, genetics, and environmental inducers of pancreatitis such as smoking and alcohol, which are clearly important covariates. And so I'll end by showing you my email because I have a tremendous amount of enthusiasm to pursue these studies that Peter Banks has charged us with conducting in the years ahead, but these cannot be done individually, and we need to do this in collaborative groups that are not only national, but they must be international so that we can learn about this disease across the world. So thank you very much.